What I'm most impressed with in the use of the KAVS procedure in comparison to the other non-tumescent, non-thermal techniques is the safety of the balloon technology, where what we can do is in treating axial veins such as the short saphenous vein and or the great saphenous vein, and we're delivering relatively stringent solutions, the sclerosing agents, up near the deep system instead of depending on an ultrasound probe compression by the physician to prevent the solution from going into the deep system. We have an occlusion balloon here which we can verify by ultrasound technique that there is absolutely no solution going into that deep system. So for me, that's a very significant and safe measure in consideration of the various types of agents that are being delivered into these axial veins at this point to close them down. The catheter itself is very easy to manipulate in the vessels. So because of its, should I say, its flexibility and pliability, even though it has the capacity to utilize a guide wire, which I think is a great plus when we're starting to deal with some of the vessels which can be tortuous in nature. This catheter has a consistency to it that lends itself to being threaded very easily, especially in the axial veins of the short saphenous and great saphenous veins. I think that the volume of fluid that's being infused into the various vessels at this point is more significant than what was done previously. And certainly we know that sotradecol and polidacanol are solutions that have near immediate effects on the endothelial lining of the vessel. And so because we can aspirate some of the additional material subsequent to what we feel is adequate treatment, this may provide a further safety measure. The difference between a 9 French and a 7 French or even a 6 French, which most of the devices today are threading through those types of sheath devices, there really is very little difference between those. What I will say is that if we are trying to access the veins that we're closing through a tributary or a little bit smaller aspect of the vessel, we can always use a smaller French access device such as a 5 French, and after guide wire exchange can easily dilate up to the 9 French. And that would hold true for any device that we're using. So whether we're using a 6 French, a 7 French, or a 9 French, at times it's been necessary to use that type of smaller access first, and I don't see it as being an issue for the patient or for the physician. There is certainly greater safety in using the non-thermal techniques, and I think that everybody is striving to utilize those instead of using thermal energy. Not that the other procedures are not good procedures. They're tried and proven. They have a very low complication rate. I myself have performed thousands of radiofrequency techniques. However, I do look forward to utilizing the non-thermal techniques more and more frequently.